cross-section through personality disorder. These disorders, group of disorders, very, very important, very relevant, not only for psychiatrists, but for all clinicians, because all of you will at one point of time, or certainly several points of time, encounter be exposed to certain patients who do have personality disorders, and that can actually make your encounters more difficult in a term of interpersonal relationship. My presentation is going to be based on Introductory Textbook of Psychiatry DSM-5 edition by Donald Black and Dr. Donald Black and Dr. Nancy Anderson. So now we're going to move to the next slide. How would we define personality disorders? Personality disorders are a long-term enduring pattern of behavior, maladaptive behavior patterns, and inner experience that deviates markedly from the expectations of the individual's culture. It is very pervasive, long-term, lifelong, rigid, inflexible, has an onset in adolescence or early adulthood. It is stable over time, does not fluctuate, and it leads to distress and impairment in functioning. Brief history of personality disorders. We can actually trace that maladaptive character traits have been recognized since Cain killed his brother Abel in ancient Greece, and it was observed and described by Hippocrates as 4 temperaments believed to embody the elements of earth, air, fire, and water. German psychiatrist Kraepelin described the personalities he found in manic depressive patients and in their relatives as depressive, hypomanic, or irritable terms that correspond to melancholic, sanguine, and choleric temperaments. This where we have roots for modern personality disorders classifications. So formal attempts to list the variety of personality types took root with publication of DSM-1 in 1952, in which 7 types of personality disturbances were described. The list of personality disorders were paired to 10 in DSM-4 and has not changed in current DSM-5. But in addition to cluster A, B, and C, so 10 types of personality disorders, we have 3 new diagnoses, which I want you to know. Number 1, personality change due to another medical condition. Then we have other specified personality disorder. And number 3, unspecified personality disorder, no elsewhere classified when you really do not know, you don't meet criteria to place the disorder in any of previously mentioned categories. As I mentioned, we have cluster A, cluster B, and cluster C personality disorders. Easier to remember, cluster A can be named eccentric disorders, cluster B dramatic, cluster C anxious. Cluster A comprises of paranoid, schizoid, and schizotypal disorder. Cluster B, dramatic disorders, comprises of antisocial, borderline, histrionic, and narcissistic personality disorder. Cluster C, or so-called anxious disorder, are avoidant, dependent, and obsessive compulsive personality disorder. As I mentioned, I'm not going to repeat, there are also, according to DSM-5, 3 new groups, 3 new diagnoses, and we're going to move further. As I mentioned, cluster A are eccentric personality disorders. What is the common characteristics? They're all characterized by pervasive patterns of abnormal cognition. For example, suspiciousness in paranoid personality disorder, self-expression, example, odd speech in schizotypal personality disorder, or relating to others, reclusiveness, schizoid. Cluster B are very dramatic. They are characterized by pervasive pattern of violating social norms or the rights of others. Example, criminal behavior in antisocial personality disorder, impulsivity, excessive emotions or emotionality, grandiosity, or acting out, like tantrums, self-abusive, self-mutilating behavior, angry outbursts that we do meet in borderline personality disorders. Cluster C, anxious personality disorders. We have avoidant, dependent, and obsessive compulsive personality disorders here. They are like fearful. They have pervasive pattern of abnormal behavioral patterns. They usually place them in the in dependent personalities. The others in dependent position, being excessively dependent on some person, and experience very hard times when they've been rejected or ignored. As for epidemiology, prevalence in general population, not in America, I think on the globe, is between 9% and 16%. I found in America it goes up to 15%. The prevalence is even greater in psychiatric samples. We have comorbidity. In some studies, 30% to 50% of outpatients have personality disorder. The frequency of specific personality disorder differs by gender. Example, antisocial personality disorders occurs more frequently in men, whereas borderline, histrionic, and dependent personality disorders are more frequent in women. Other personality disorders have a fairly equal gender distribution. Prevalence diminishes with advancing age, so younger persons are at greater risk related to early onset. Other general risk factors are lower levels of education and lower socioeconomic status. Substance misuse and cigarette smoking are more frequent among those with a personality disorder than those without. Prevalence, you can just make a quick look. You're not supposed to know that, but what is interesting, the most common personality disorder in America is actually obsessive compulsive. So don't rely too much on this table. I found that it's OCD and very, very closely followed by it's borderline. So obsessive compulsive disorder and then borderline. All others are presented with a few percents, but altogether comprises a significant group of personality pathologies in our country. Importance of knowing how to approach the patient with personality disorders. Why is it important in clinical settings? Knowledge about these issues will help us with understanding confusion about why patients do not act as we expect them to act. Why emotional distress arises, and they may elicit actually emotional distress, and also will help us with protecting us from inappropriate relationships and engaging in medical practice outside our standard of care. So next slide. I have frozen. I don't know, is anything possible to move further? Aha, thank you. Etiology, likely multifactorial etiology, like almost all other psychiatric diagnoses. So we have genetic, hereditary components and factors, plus environmental factors such as chaotic home environment and abuse that have been implicated in development of maladaptive behavioral patterns. Numerous family, twin, and adoption studies have explained the role of genetic factors in the etiology of schizotypal, antisocial, and borderline personality disorders. However, in contrast, other personality disorders have not been involved in research that much. So this is heritability of personality disorders. It's good to have this list, and it is actually taken. I don't know how to move the bottom toolbar. Can anyone actually? Because I want you to see what references have been used here. And can you see the bottom? Targison, Coolidge, authors?
Yes.
Yes, okay, excellent. So this is only myself that have this on the bottom. So as we can see, actually, that very strong heritability has been presented where we see where here borderline. You see 0.61. And the thing is, we have here mean obsessive compulsive. Also, then we have others. Genetic personality disorders, we actually authors and scientists, they, for comparison, they actually have heritability of normal personality traits that is approximately 0.5. So now you can compare the results and the means on the previous one that we have 0.6 for borderline and for obsessive compulsive. Molecular genetic studies of personality disorders indicate the genes linked to neurotransmitter pathways. Particularly, this is important for neuroscientists, future, serotonergic and dopaminergic systems is a rewarding system, and we already saw a few days ago they're involved. Now we have a brief presentation of each. So to recap, cluster A, the individuals with cluster A group personality disorders appear odd and eccentric. It's a paranoid schizoid schizotypal personality disorder. Cluster B, individuals appear dramatic, emotional, or erratic. We have antisocial, borderline, histrionic, narcissistic personality disorder. Cluster C, individuals appear anxious or fearful. We have here avoidant, dependent, and obsessive compulsive personality disorder. Let's see briefly paranoid personality disorder. What is it about? This person has a pervasive, permanent distrust, mistrust, and suspiciousness of others, such that their motives are interpreted as malevolent. So they always make questions, or maybe he did this for me, maybe she set me up, maybe maybe she has a microphone and she's listening to my conversations. So they have questions about everything, and usually when they express, and they do express it, they place themselves in a big interpersonal relationship troubles. Schizoid personality disorder, well, just leave me alone. That's the rule for these persons. It is pervasive pattern of detachment from social relationships and restricted range of expression of emotions. These persons are happiest on this planet when they're just by themselves, okay? So please leave me alone, and I am on my way to go optimal functioning, right? Which is actually not. It's maladaptive behavioral pattern. schizotypal personality disorders, they are very interesting. This is a pervasive pattern of social and interpersonal deficit marked by acute discomfort with close relationships, as well as by cognitive and perceptual distortions and eccentricities of behavior. These people, these patients, they believe in magical thinking, right? In hidden clues, hidden signs, hidden messages, and they're very strange. They're very strange, and as we mentioned, like was others, it's a permanent, long-term, lifelong behavioral maladaptive pattern that places them in social and occupational and relationship trouble. Antisocial. Well, antisocial personality disorder is very bad for others. Okay. In contrast to the borderline personality disorders that are very bad for themselves. So we have here the essential feature as a pervasive pattern of a disregard for the violation of the rights of others. They really don't care. They usually have a history of violating animals, torturing their classmates, ruining furniture, and usually since age 15. We usually have synonyms, sociopathy or psychopathy for those ones, for these ones. They usually end up in prison. Borderline personality disorder, it's pervasive pattern of instability of interpersonal relationships, chronic feelings of emptiness, distorted self-image, distorted affects, marked impulsivity. They often engage themselves in maybe substance abuse, self-mutilations, suicidal tendencies, ideations, and attempts. Histionic personality disorders, that's pervasive pattern of excessive emotionality and attention-seeking behavior. They really want to be on the stage all the time. They want to be they need affection, and they usually have very, very attention-seeking behavioral patterns. Narcissistic personality disorder, well, they deserve the best. They're entitled for the best. If it's not met, if this is not the case, they have big discomfort, they have big distress. It's pervasive pattern of grandiosity, need for admiration, and lack of empathy that begins by early adulthood. So they really don't care if they have disabled person waiting for physician's exam, if they think that they're entitled to be the first that morning, regardless the time schedule or how you schedule them in your doctor's office. Avoidant personality disorder, well, a pervasive pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. So they usually avoid going to take the test because, oh my God, I'm not ready enough. I'm going to fail the test. So it's better not to take it. So usually they avoid social happenings, having chronic long-term fears that they're going to be rejected or maybe ashamed, or that something really bad is going to happen. So they avoid all pseudo-frustrating situations frustrating according their attitude, their imagination, or their imprint, synaptic imprint. So here we have dependent personality disorder. Well, it's pervasive need to be taken care of that leads to submissive and fears of separation. Usually, we have that in abusive dyads, like partnership, when one partner is dominant, abusive, the other partner is emotionally linked, cannot leave. Just can't imagine living without the person who actually gives a pain. It's not SM combination. I'm not talking about sadomasochistic combination. It's just kind of like the person is not comfortable, but it's kind of needs to have somebody to rely on, just to move on, or just to feel better, not to experience that horrible distress and discomfort when something is out of their rigid frame. Now, we have obsessive compulsive personality disorders. They're very interesting. Everything has to be aligned. They're preoccupied with order lines, perfectionism, mental and interpersonal control. They need to know exactly what's going to happen in 3 weeks at 12:30 p.m. in order to relieve their distress. Or they have to have all little papers nicely, neatly sorted. Otherwise, they're going through a very bad distress that actually express itself as an anxiety and ruins interpersonal relationship at work, at family, in their families, or in society. We have a passive aggressive personality disorder. Well, passive aggressive personality disorder is I don't like you. I'm not going to tell you that I dislike you, but I'm just going to move you off the list. You know, you just kind of like passively, and you never know what happened. So it's negative attitude with passive resistance to demands. And we have a general impact on patients' functioning. This is very important. Social significance of personality disorders. Personality disorders can cause enormous problems for individuals and are frequently associated with impaired interpersonal, social, and occupational adjustment. Family life, marriages, academic, and work performance suffer. So we have rates of unemployment, homelessness, divorce and separation, domestic violence and substance misuse are high. They are associated with increased rates of healthcare utilization, emergency department visits, hospitalizations, and excessive rate of traumatic accidents. The risk of suicide is about the same as that seen for major depression, particularly borderline. Nearly all patients have one or more comorbid mental disorder, mood disorder, anxiety, substance use, and eating disorders, binging disorders particularly. And comorbidity affects the course and outcome of a comorbid mental disorder. How are you going to make a diagnosis? Patients with personality disorder have no or have a very little insight into their disorder, difficulties that their maladaptive traits create, and thus they're prone to view others as the source of their problems. So she's not gonna come to you and say, oh, I have some problems. So they rarely seek help and are diagnosed in the context of other ongoing troubles in functioning or chronic depression that lead them to seek the help. What is the diagnosis about? It includes thorough personal and social history, careful mental status examination, specific questions regarding the patient's attitudes and behaviors. Collateral information from relatives, the police, social workers, a parole officer also is important when patient denies, and they usually do deny, maladaptive traits. So this is also very important. The age requirement. If the patient is younger than age 18, you need the disorder to last a minimum 1 year to make the diagnosis, with the exception of antisocial behavioral disorder that really needs full age of 18 to label and to put and to stick the diagnosis on the patient. Differential diagnosis, the most important differential diagnosis, and keep that on your mind, is actually exaggerated personality traits, right? Minor personality quirks or idiosyncrasies that rarely rise to the level of disorder, as most people learn how to adapt to changing circumstances and learn from experience, like Dr. Stein said, resilience, building resilience. While a person with personality disorder persists with maladaptive behavior regardless of the consequences. Secondly, cultural issues, as certain traits may be considered normal in some societies. So this is the second differential, very important, cultural issues. So certain traits may be considered absolutely normal in some societies, but not in others. Believe in magic, in sorcery, in certain cultures, I'm not sure of South America, but in contemporary American society, they may be viewed as magical thinking associated with schizotypal personality disorder. Treatment. Well, treatment, we may say that there is no the United States Food and Drug Administration approved psychopharmacological treatment for pure personality disorders. So psychotherapy is still the mainstream and backbone of the treatment. However, a very specific treatment is required for borderline personality disorder, BPD. It's dialectical behavioral therapy. It has to be at least 1 year long, and even then, it's very, very, very uncertain. Are we going to hit the therapeutic target with the patient? We have intensive 1 year long treatment. Schema-focused therapy is also has been proven as a good one. Transference focused therapy and mentalization-based treatment, they have all been found to be effective. In other personality disorders, we stick with individual, group, family psychotherapy, maybe CBT also. It takes time. They're very reluctant to treatment. As for medication and psychopharmacology, SSRIs, usually fluoxetine, and antipsychotics, they're indicated if the patient has comorbid depressive symptoms or suicidal ideations or suicidal behaviors. And we have to be cautious about prescribing benzodiazepines, as I mentioned, particularly in patients with borderline personality disorders. They have increased risk for suicide. Therapy for other disorders is limited to a small number of open label trials and case studies. These findings have been positive, however, and as I mentioned already, there are currently no medications approved by US FDA for any personality disorder, hence psychological interventions, individual and group psychotherapy are still the backbone treatment, with some novel modalities that are used in studies right now. We have experiments with virtual reality exposure, and it's a bunch of attempts. So we're going to see within the next few years, up to 5 years, the outcome. So that would be all, and thank you for your attention. I would like to hear your questions and any inputs. I would highly appreciate it.